we're going to get started here. This is the version 6.22 upgrade call for congenital. Today, we're going to walk through administrative through hospitalization. On the line with me, we have quite a nice group of folks from STS. We have, of course, Leanne Jones. This is Carol Crone. We have Leanne Jones, Addie Dolan, Emily Conrad, and Melinda Offer, who's our adult cardiac consultant, as well as Chastity Wellness, who's our congenital consultant. We have Jean, Janet, Dr. Nelson, Joe Brower, Case, Leslie, Melanie, and Michelle Choi, all here to help us out today with this call. As I said, we're going to start with the administrations section and then go through hospitalization. Questions will be asked to be focused on the sections we're going to review today. And if there are other questions, we'll try to get to those after we get through the questions that are related to the topics we're discussing. I just wanted to give, our next webinar will be February 22nd. We'll start with pre-op factors through pre-op labs. I just want to give you all a second to go and pull down the data collection forms. Leanne has them posted in Word. So if you go to sts.org, the STS National Database, Congenital Access Data Collection Resources, and then under version 6.22, you'll see each of the forms posted in Word as well as the PDF. Word is going to be nice if you want to pull down this fourth one here and give it a few seconds to download onto your computer. You can take notes in the column there then a little bit easier than you could do on the PDF section. So I'll give you all just a few seconds, a few minutes to pull that down. And then we'll get started walking through. So that's what I'm going to pull over. I have, I didn't mean to do that. One second. I have the forms open behind me here. And be sure to enter your questions into the Q&A. Today, we're going to walk through the administrative demographics all the way through the hospitalization section. The form on the left is going to be the current data collection form from version 3.41. You'll see fields highlighted in yellow. These fields have been removed. Fields highlighted in green means fields were probably, if you see them crossed off, they were moved from that section to another place and live within another place on the data collection form. The form on the right is the version 6.22 data collection form. You're going to see a lot more, a lot of different things going on over here. You're going to see blue, green, and the different colored backgrounds. The blue fields are things that were maybe added in or just updates to the spelling. You'll see the annotated text here. Typically it's in red. This is a field that has lived in congenital and no changes really to this field. When you see things in green, we're pulling it over from the adult cardiac. That's just really to help Chastity and Melinda as they're working on the data collection form, pull over those intent clarifications where they make sense for the congenital or adults with congenital population. So the first thing, we don't have any changes. We'll start with administrative. We don't have any changes here. Again, just your participant ID will auto-populate. STS-related clinical trials are those trials that are sponsored by STS. If it is a trial that STS is involved with, you'll find information in the training manual on how to code both the clinical trial and the clinical trial ID fields. Currently, I think there's one. I'm not sure if it's in the training manual yet, but it will be. The next section is the demographics section. In the current form, we didn't remove anything, but we did add some things into version 6.22, the form on the right. As we talked about last week, we are going to collect fetal interventions, and those are fetal surgical interventions. For the medical record number for those fetal interventions, you're going to enter the mother's MRN followed by the word fetal. So for example, it would be 1, 2, 3, 4, 5, 6, and the word fetal spelled out. This will help identify that those are fetal procedures. when you're entering the data and when we're looking and doing analysis on those. Same fields, last name, first name, middle name, postal code. We did add in permanent street address and city. Both of these fields are considered PHI, protected health information. Some sites are not allowed to enter this in due to reasons at their hospital, as put forth by their legal team at the hospital. However, if you do not have those types of restrictions, we really strongly encourage you to enter in both street address and city. The reason for that is we are trying to do geocoding, which gets down to the patient's street address, and that helps with determining socioeconomic factors in outcomes and the need for certain procedures. So the more information we get that contain, the more data we get that contain street address and city, the better we are to pinpoint disparities of care and socioeconomic factors, including the type of place the person lives, the usual income of that block, things like that, so to help us better care for patients who might have a lower socioeconomic status. It also helps us to understand their outcomes better. So if you're able to provide this and you don't have any restrictions local within your hospital or on the state level to provide this, we strongly encourage you to provide that. The next, we get into patient region, which is your state. If you are a United States facility, if you are a international facility, there will be instructions in the training manual on how to enter these fields. Race documented, this is going to be a yes or no, and if the race was documented, we added in this new field, which is the race multi. We removed the yes or no boxes from all of these choices. So you just have to select what applies to the patient. It's a pick more, it's a select all that applies, so you can pick more than one. So that's the change there. And then, of course, the Hispanic or Latino ethnicity needs should be answered on all the patients. You're going to answer these according, for fetal interventions, you'll answer these according to the mother's information. And again, all that information will be provided in the training manual. We're going to get into birth information next. We have over on the left-hand side, you'll see the fields born by IVF, patient adopted, birth location, mode of delivery, mother's gravidity, APGAR score, mother's information. This has all been removed from this current version. It will still live in your past demographic tables, but it will not be available in this version. You will not collect it in this version, but it will still be in your historic data. The first question we get to on the right-hand side is, has the patient been born yet? Yes or no? And this field is going to help us identify if this is a fetal intervention or not. If the patient has not been born yet and it's a fetal intervention, you're going to check no here. These fields will not open: the date of birth, blood type, birth information. They will not be available for fetal intervention. You will get the multiple gestation, the antenatal diagnosis of congenital heart disease, and pregnancy-related complications for fetal interventions. You will need to fill these out for fetal interventions. If you select yes here, has the patient been born, then you'll get all of this other information, including date of birth, sex at birth, blood type, RH factor, and then the birth information, including weight, premature birth, and gestational age at birth. The complications section will be answered for all patients. This is, again, this believe was all yes or no fields before. We have made it a select all that apply. And we added in fetal alcohol exposure. So complication for fetal alcohol exposure will be if that, if the fetus was exposed to alcohol, not if the fetus was born with fetal alcohol syndrome. This is just related to exposure within the complication section. We get into the syndrome when we get further down into the preoperative risk factors. Again, maternal diabetes is up in this section as well. Chastity, is there anything you'd like to add here? for this birth
Sorry, I'm on
information
mute. No,
section.
I think that this was a great overview, understanding that not all of the questions do you need to fill out if you are entering information for a fetal intervention.
Okay. We're going to move on down now. So on the left-hand side, you'll see this is the 3.41 form. These are the fields I was talking about related to pregnancy, related to complication. All of these yes, no, or unknowns have been removed, and we're only going to ask you to code this if you have a positive, if you can say for certain that these are positive as complications for the baby or for the fetus or for the patient. And then we've removed last follow-up NYHA classification. You'll no longer need to collect that information. The date of last follow-up, this isn't coded in green, but it should be. This was removed down below to the follow-up fields, down towards the bottom of the data collection form, and we'll get to that towards the end of our review of the data collection. The next section here, we get to the non-cardiac congenital anatomic abnormalities. We changed these. This is now going to live on the demographics table. And we're going to code these so it'll live with the patient as you code them. It will live throughout multiple procedures. And no real major changes here. We added in the major abnormality of the spine, kyphosis and lordosis. But other than that, no major changes. And then we get into the chromosomal abnormalities. In just a few, we moved this Mensomany X up with 45X0 for the chromosomes. And then we removed, you'll see we were, I think, double capturing these, trisomy 13, 18, and 21. We are capturing them up in one of the other sections, maybe down below here. But they're here. I think we were double capturing them somehow. Okay. And then other genes identified with the abnormalities, it's select all that apply. No major changes outside of this addition of BMPR2. RYR2, R506Q, and TRDN have been added in. No other changes. And the syndromes. We're getting pretty good here. We're moving right along. So for the syndrome section, this is also going to be a select all that apply. We added in parents to both of these. I should have pointed that out. We added in parents to these fields where it's non-cardiac congenital anatomic abnormalities known, yes or no. If you select yes, then you have to choose the list. Previously, these were, I think, all showing up as yes or no on the data warehousing side. So it's no longer will be that way. These will be delineated fields, a delineated field separated by commas when you select all that apply here. And then the same thing with chromosomal abnormalities. You'll have a parent here. And if you select yes, then you'll select your chromosomal abnormalities, all that apply. If no, then you just skip on down to the syndromes, and same thing with the parent field addition. I'm going to try to talk to these. I don't know that I remember every reason why things were removed, but this familial ASD, familial non-syndromic CHD, distinct disorder, and non-syndromic CHD were removed. And I have a feeling that we were collecting those in different ways. And I think we were double capturing some of these, so we removed the choices to help avoid double capture. Added in spinal muscular dystrophy. As you can see here, we had, I remember this when we had spinal muscular dystrophy. Spinal muscular atrophy type 2 and syndromic CHD. They combined this just to be spinal muscular atrophy.
Yeah, Carol, I think it was the point we could only collect it if it was SMA type 2, which there are other types. And so we wanted to make sure that we're collecting all patients with SMA.
Great, thank you for adding that clarification in. And then we get into the hospital name, the hospitalization. No major changes here. We did add in the hospital CMS certification number. And this is something we will provide you information on how to obtain this, but this is your, if you're caring for patients who are Medicare, Medicaid, you will have a CMS certification number if you're getting reimbursed. So that number can be filled in within your vendor software and just auto-populate here. You wouldn't need to enter it in for every case. And then that's pretty much it. We're still going to collect data on the COVID patients. We did it in 2 calculated fields, BMI and BSA. Both will be calculated off of your height and weight. This is height. This is weight. I'm sorry, this is weight. This is height. And those will be calculated in through your vendor software, so you don't need to enter anything in. We'll provide the calculations to your vendors to implement those fields to auto-populate for you. So I guess that's where we're going to end right now. I'm going to go to the questions. If we have time, we can move on. If Chastity and Melinda, and Leslie, Janet, if you feel comfortable moving on to the pre-op factors, we can certainly do that after we get through the questions that are open now. And Chastity, I'm going to probably hand some of these off to you because I don't like always being the one speaking all the time.
Absolutely, not a problem.
Okay. And we can also loop in Dr. Nelson, who has been so kind to join us for this call. The first question is, with fetal intervention procedures, is it going to be hospital choice to include these, or is it going to be all-inclusive for fetal interventions done by our pediatric congenital surgeons? It is going to be all-inclusive. We aren't giving a site an option if they want to or don't want to include these. Chastity, do you have anything to add to that?
Yes, if they're done by your surgeons at your hospital, you're definitely going to want to include these. So not optional for sites not to include them. Correct.
Thank you. This question is from Cindy. If a patient has a fetal intervention and then another procedure after birth, do we change the MRN at that point? And I can take that one. So
Okay.
we're not asking sites, and I can show you a little bit more how we're going to, let me find it here. It's further down a little bit. And we didn't really get to that part where we're asking. So when we are talking about fetal interventions, this is the status post section. You'll see this field status post fetal intervention. This will be post birth, right? Patients now, patient originally had a fetal intervention. Now they're coming back for another intervention. We're not going to ask sites to link those 2 procedures. That will be very difficult, especially if the fetal intervention is done at a specialty hospital that is does the majority of these fetal interventions, like Leslie's hospital, for example, at Michigan. We're going to ask you just to code fetal intervention for the baby and enter in the baby's MRN on a DCF. We will connect these on the backside with whatever information you're able to provide to us. So if you have the location of the fetal intervention, if it was this hospital or a different hospital, if you have the STS participant ID, if you have the patient ID and the operation ID, that's all very helpful. If you don't know this information, don't worry. We ask that you try to get it, but we don't want to cause extra burden to you if it's not handy to you. We don't want to cause you years of trying to track down these patients and their fetal interventions. We can try to do it on the back end using a couple different ways. But for a patient, for a fetal intervention, you're just going to enter the DCF for that fetal intervention, enter the mother's medical record number followed by fetal. When that baby comes back, either if it's at your hospital or a different hospital, you're just going to enter a new DCF with that baby's or patient's MRN. and do our best to link it using this information if it's available to you.
I
I think
think,
I covered it.
Carol, this might cover the next few questions, that you're never changing an MRN after the baby's born or otherwise. The baby will stand alone in the database, and the fetal procedure would stand alone in the database.
Yes,
And they'll
that's
be
right.
linked upon analysis, not by us on the front end.
Right. So, right, for Ruth's question, Ruth is asking if Ruthie's asking if you don't have the mother's MRN procedure done at another institution. So you're only collecting this, you're only going to fill out the DCF for this fetal intervention if it's done at your hospital. And so I hope that answers, I hope Chastity answered that.
Yes, you're not collecting, you would use the status post fields that Carol just showed to collect interventions done on a baby that's already born that you're entering a new procedure on in your own database. If you didn't do, my hospital doesn't do fetal intervention, so I won't ever enter the fetal interventions. I would enter them as status post if perhaps we sent a baby to Leslie's hospital for intervention.
Thank you, Chastity. And we'll provide all of this very clear instruction within the training manual. I think you did a great job explaining it. And I'm just going to remind people to please enter your questions into the Q&A so we can keep track of them that way.
Hey, Carol, real quick, sorry, it's Leslie. Just a reminder, this is only collected with the procedures that your surgeon is doing or participating in.
Mm-hmm.
Yes.
That's right. Yeah, I think we're going to get to that question in a second. But that's right. This is just for procedures that your surgeon is performing. We're not capturing interventions, right? Patient born will be updated by ADT interface as well as by other registries. Once the patient is born, this will remove the value and therefore become. So like Chastity said, we'll be using separate data collection forms. The fetal data collection form will be separate from the baby data collection form in two different sets of demographics.
Mm-hmm.
How will the fetal interventions capture when the mother's MRN links to? So that's why we're going to add the words fetal after the MRN. You're able to put in both numbers and letters into this MRN field. So that's why we're going to add this word fetal, and then it will not match the mother's MRN number. Any idea how the changes to the NCAA chromosomes and syndromes will interact with PC4 and PAC3? Will changing them to have parent fields mean that the data manager can no longer, that the data can no longer be shared with the other registries, and we will have to duplicate the data entry for STS and other registries? Chastity, are you comfortable taking that one, or is that one, or Leslie,
I mean, it really depends on if I guess who your vendor is and how they interact with PC4 and PAC3, the other cardiac registries. I think Owen is on the call. And he is willing to provide a response if that's okay.
Oh, Owen, raise your hand. I'll be happy to move you over here. Owen, are you there?
I can see him typing in the chat, so I know he's on, but.
Oh, there you go.
When you made me a panelist, that had made me rejoin the meeting. So, so I've already spoken with the other registries, and so we'll handle the parent-child field in the specifications, but essentially any new values they receive, they'll accept. So if you have new diagnoses, new procedures, non-cardiac abnormalities, chromosome syndromes, the PC4 and PAC3 registry will accept that.
Thank you, Owen.
You're welcome.
And then your question is the next question about providing calculations and within for the specifications. And Paul's working on the software specs now. He hopes to have those out by the end of the week. And we are providing the specific calculations for all the calculated fields.
Yep. And thank you to Chastity for explaining the fetal patients will be essentially isolated patients. There'll be no follow-up, or there won't be any like subsequent surgeries on those patients.
Yeah, that was good. That was going to get very complicated if we tried to link those on the abstraction side. So a decision was made not to link them, and we can try our best. If the site has the fetal interventions procedure ID, we can try to link it on the analysis side or on the back end of it, but we didn't want to put that burden on sites to have to try to track down that information.
Perfect. Thank you.
Thank you. Okay, Seeing no more questions and that we have a half hour left, Chastity and Leslie and Melinda, are you comfortable moving on to preoperative factors?
Yes, absolutely.
Okay. And Melinda, I know you're there, but I just can't hear you.
Can you hear me now?
I can hear you now. And for all of you who don't know, Melinda, if you weren't on our last call, Melinda is our clinical consultant for the adult cardiac registry. She's been with the registry for numerous years. I won't give it away how long. And she's been our consultant for 3 years now, a little over 3 years now. Okay, so the next section we're going to talk about is the preoperative factors. This is where we get a little bit more complicated. I don't want to use the word complicated, but we have to pay a little bit closer attention as we walk through this section to explain the shading of the background of fields. So up above in the key, you would see that the light red background, these choices are only going to be available for the under 18 population. Fields that have a purple background, which you'll see down below, are going to be fields or options that are only available for the 18 and over population. So within the data specifications, we were able to include 2 parents for some of these fields. One would be the actual parent, and the other one was the age days parent that identifies if the patient's 18 or over. So within the preoperative factors section, we didn't really remove anything. We did add a few choices. You'll see here, again, we have this parent, the preoperative factors, yes or no. And if yes, then you're going to select all that apply. We're going to do, as Chastity and Melinda work through the training manual, we'll work, of course, with the various core group members and both adult and congenital to help with this. Making sure that our definitions align as much as possible. We tried to do a lot of pre-work on the upgrade calls, reviewing each of these definitions and seeing if there was a discrepancy between the definitions. How could we help get over that difference within the upgrade? And then we made notes and comments about things that needed to be included in the training manual to provide clarification on these fields that may be new to the congenital data, to the congenital data managers. So a lot of pre-work has already been done talking about these definitions, but there is further work that needs to be addressed as we move forward in building out the training manual. So preoperative factors, you'll see these 3 in red with the light red background. They're only going to populate for the under 18 population. And I'll talk more on that, why that is in a bit. It's not that it's not important to the 18 and over, to the adults with congenital population. It's that we collected a little bit differently down below for the 18 and over. So if you have a patient who is under 18, all of these choices will open with the red or white background. If you have a patient who's 18 or over, you will not see these choices with the red background populate. So they will not be an option to choose for those patients. As we scroll down here, you'll see we added in a few more for everybody. For all population, you'll see we added in this preoperative dysrhythmia requiring antidysrhythmia medication, illicit drug use within 1 year, immunocompromised, mediastinal radiation, a family history of coronary artery disease, heart failure, and chronic lung disease. All of these choices here with the white background, they'll be available for the entire population, for all patients who you're entering a data collection form for. These choices here will only, with the purple background, will only be available for the 18 and over population. And this is where we get into up above where we had the preoperative complete AV block only open for the under 18. You'll see down here we have this cardiac dysrhythmia only opening for the over 18 population. And the reason for that is that we get a little bit more granular with the 18 and over population and the types of dysrhythmias that we're interested in collecting. I'll show that down below in just a second. So hypertension, sleep apnea, liver disease, liver cirrhosis, cancer within 5 years, peripheral artery disease, syncope, unresponsive state, cerebral vascular disease, and myocardial infarction. These will only open, you'll only have these options available to code for pre-op risk factors if the patient is 18 or over. And again, cerebral vascular disease, you'll see this here. It's not that we don't care about it for the under 18 population, but we're collecting it differently. That was these two questions up here regarding stroke, grade 2 during the lifetime or grade 2 within 48 hours prior to surgery for only the under 18 population. For the over 18 population, we're going to collect it a little bit differently, and we're going to get more granular with the information that we collect for the adults with congenital. So going down, another thing that we added in this section are parent-child relationships to get a little bit more granular information about some of the specific preoperative factors. And you'll see here on the left, we have endocarditis. I'm looking at this left-hand column here. You'll see that for endocarditis, illicit drug use, shock, diabetes, liver, chronic liver disease, cerebral vascular, myocardial infarction, dysrhythmia, AFib, dysrhythmia, pacemaker, tobacco use, heart failure. You'll see that these are all options that are up above in the pre-op factors. If you select one of those options, then the children fields are going to open. So if you select endocarditis, this is available for all patients. If you select endocarditis, then the additional fields that are going to open will be endocarditis type. Is it active? Is the patient currently having positive cultures? And we'll get more into the definition within the training manual. Is the patient active or has it been treated? And if it is active, did they have a culture? Usually we know that it's active because they have a culture. What did that culture show? So this will be collected on everybody. And this is to get a better understanding of the types of endocarditis that your patients are entering the OR with. The second question that will have children is if it was chosen to be illicit drug use within 1 year. So if your patient had illicit drug use in 1 year, was that drug use IV? Was the illicit drug use within 30 days? So these are two questions that will need to be answered additionally if that patient did have illicit drug use within 1 year. Shock is the next field that we have children on. We have shock resolved at time of surgery. What we want to know though was that was it resolved within 24 hours prior to surgery? So the question up above is, did the patient have shock and was it resolved at time of surgery? So let's see what that says. We have two questions here: shock persistent at time of surgery, shock resolved at time of surgery. There aren't any really clear timelines that can tell us if that patient was in shock within the 24 hours leading up to surgery. We only know that it was resolved at the time of surgery, but we don't know when it resolved, and we don't know really this is going to tell us the hemodynamic stability of that patient within the 24 hours prior to entering the OR. So to get a better understanding of that patient's hemodynamic status, we want to know, was it resolved within 24 hours? If you answer no, that indicates that that patient was pretty unstable going into the operating room, even though it was resolved prior to entering the OR. Diabetes, non-insulin dependent, and greater than 18. Now you're going to see these fields have the purple background. These are only going to be available. You're only going to have to answer the more granular questions on the 18 and over population. So the questions up above, one of the choices is the diabetes non-insulin dependent. And that's an option available for everybody. We have diabetes insulin dependent and diabetes non-insulin dependent. Whatever you choose here, the options available for both patients, both the under 18 and the 18 and over groups. However, if you choose the diabetes mellitus non-insulin dependent and that patient is 18 or over, we want a little bit more information on that. We want to know what type of diabetes control. If they're not on insulin, then how are we controlling their diabetes? We only care about we care about this for everybody, but we're only interested in this for the 18 and over population at this point. The other question, of course, liver cirrhosis and over 18, we're going to want the Child-Pugh class score. This will be something that the surgeon or the surgeon's documenting or the GI physician is documenting. This needs to be charted by the physician, and this will be clarified in the training manual, but this will only be coded for the 18 and over population. Chronic lung disease is one of the more trickier ones. And we have, Melinda, I don't know if you want to talk more about this, but I can just say for chronic lung disease not associated with premature birth. So chronic lung disease not associated with premature birth is an option. I think that's an option for everybody. I just want to find it here 1 second, please. Here it is. Chronic lung disease not associated with premature birth is an option for everybody. So if a patient is positive for that, you would select that option. If the patient's 18 or over, you're going to get additional questions. We want to know the severity, mild, moderate, severe lung disease, documented, but severity is unknown. The severity coding of severity is based off of a hierarchy of different things, including FEV1s and the use of bronchodilators. This, we provide extensive information in the training manual on how to code chronic lung disease, but it is one of those tricky fields. And Melinda, I don't know if you have anything you want to add here, just besides it's a tricky field.
Well,
for the
I
adult
think
population.
it's tricky because a lot of times the surgeons will document the degree of lung disease, and that's not really what the definition is. The definition is it's based on criteria, and we have FEV1 criteria, we have inhaler criteria, we have ABG criteria. We've even got some DCLO criteria. So the key to this field is that it has to meet the criteria in the training manual, and it's not physician documentation. That's the main key, and that's why it makes it so tricky. And even adult new data managers struggle with this for a while, but we have a lot of good information in the adult training manual, which I'm sure Chastity and I are going to transfer over to the congenital training manual. And I of course, will be available for questions, and Chastity, we can work through these questions, but that's why it's tricky.
It is tricky.
And we say this a lot in congenital as well. It's not always what your clinicians are documenting. You need to make sure that we're all working off the same set of criteria or definitions for the database.
Yeah, it's very true. And I think Melinda did something really nice. I think in the adult one, Melinda, did you add in source of documentation?
Yeah, we have a lot of notes in there. We have all kinds of, I mean, the definition for this is probably one of the longest ones in the training
very
manual.
long.
So it's very extensive. It has a lot of information in it. And I think the most confusion is that your surgeon's documenting that the patient has moderate lung disease. But when you look at the criteria, the patient only has mild. And the key is you got to go by the criteria, because that's how we determine severity. And we can work through this. It's a little tricky, but once you get it, you get it.
Yeah, we might even have to do a separate webinar once we get the version going and out the door, and folks are abstracting. We probably should do a focus webinar just on collecting the chronic lung disease fields, because it has been a pretty difficult, and it is important in the outcomes of prolonged ventilation and things like that. So capturing it right and making sure that the risk is assessed correctly is really important. Thank you, Chastity and Leslie. I know this one's going to be tricky in the training manual. The next thing that you're going to answer here is the mild, moderate, or severe. If mild, moderate, or severe is selected for the severity of lung disease, you're going to answer the type of lung disease, and we'll provide pretty good, we'll provide good instructions on what each of these types of lung disease represent and how to determine the type. Now we're going to get into cerebral vascular disease in the 18 and over population. Up above, those were there were the 2 pink fields, light red background field for the stroke that are only going to open for the under 18 population. And then we had this field here related to cerebral vascular disease for the over 18 population. So 18 and over. So if you select cerebral vascular disease, you're going to get this additional information regarding timing and different types of carotid stenosis. So prior CVA, and if they did have a prior cerebral vascular event, when did that happen? Did they have a prior TIA and prior carotid, or do they have carotid stenosis? This is at any time, right, left, or both. If they had prior carotid stenosis, we want to know the severity of that on either side, and then the history of carotid artery surgery or stenting. For prior myocardial infarctions for the over 18 and over population, we're interested in when that prior myocardial infarction occurred. And then we get into the dysrhythmia section. This is related to, up above, we removed that field for the adult population, this pre-op complete AV block, and we added in the option for the cardiac dysrhythmia. So if you have an 18 and over patient who has a cardiac dysrhythmia, we want more information on it. And this chart, you'll see it kind of goes up and it goes down. So the first question here, if they do have a history of cardiac dysrhythmia for the 18 and over, VTAC, VFib, yes, no, that's not present, or remote greater than 30 days pre-op, or recent within the last 30 days pre-op. Same thing for sick sinus syndrome, A-flutter, AFib, second degree heart block, and third degree heart block. We get quite a few questions about patients who go in AFib, A-flutter, might be documented AFib flutter. And we tell you, I think we tell you to code both. Oftentimes it's very difficult to tell when a patient who is in A-flutter if they ever go into AFib. So it's just safe to assume that they probably do have a history of AFib as well. For patients who are documented as AFib, we want to know the fibrillation type. Is it paroxysmal or persistent? There are definitions. I can't recall the paroxysmal. I don't remember the timing on that. Melinda, you can help me, but I know it's in the training manual. Persistent means that they underwent treatment, but they never regained being out of AFib. And then, was patient in AFib or A-flutter at time of OR entry? Yes or no? The reason why this is important is because we look at new onset AFib. This field will remove your patient from that cohort, so they would not be considered to be a new onset AFib or A-flutter post-operatively. And then we ask about permanently paced rhythm, and then more information on tobacco use regarding everyday, someday, or status unknown, former. Heart failure will answer additional information on everybody, and we want to know the timing, acute, chronic, or both. If you're able to tell systolic, diastolic, both, or if it's unavailable. And then this is a new question that's added, so we'll have to work, but the involved ventricle and how to tell which ventricle was involved. That's information we'll have to work with the surgeons on in providing clarification in the training manual for that. And then primary coronary symptom for surgery. This is the coronary symptom. If they are not having coronary symptoms, then you just code no coronary symptoms. This is going to be things, the main symptoms that were present that led up to surgery. We have things like stable angina, ST elevation, MI, angina equivalent, unstable angina, and non-STEMIs. Home oxygen use, pneumonia, and alcohol use will be collected on the over 18 and over population. And I'm going to stop there. I guess any of my colleagues have anything to add? Melinda, Leslie, Chastity, Leanne, friends?
No, I
This is-
think we do have a couple questions which probably might prompt more
Okay.
conversation.
All right. First question is from Nancy. Did you mention we will have the option to have 2 separate forms for under 18 and over 18? Yeah, we'll work on those after the vendors start getting certified or start in the process and we get any feedback from them. Usually they're really good at identifying issues on the current DCF that we provide them, and rather if it be spelling errors or if the parent-child relationships aren't adding up correctly, sometimes they catch things that we didn't catch during the original build of the data specifications. So once we start getting feedback from them and we're confident that the data collection form is, we're 99% confident, but once we're 100% confident, then we'll make 2 separate data collection forms, one for the under 18 population and one for the over 18 and over population. Why isn't cancer within 5 years considered risk factor for under 18? I think it would be considerable risk factor for under 18. And Dr. Nelson, I don't know if you're available or if you had to step away, but would you like to address that question if you're available?
Sure, I mean, I can try. This was already studied and considered a risk factor in the adult population. I was part of those discussions with the ACHD crew. After we made a decision about which variables we would recommend to the larger CHSD upgrades task force, they took all the adult new variables we were considering and discussed those for possible inclusion in this upgrade for the under 18 population, and it was not selected. I'm sorry, that's a long way to say I don't know why it's not included here, but my guess is that it hasn't been previously, like there's no previous collection of data with which they could have verified that. So it's not going to be a new risk factor in this iteration.
Okay.
I think Dr. Subramanian might be able to speak to the specific details of those conversations, though, maybe over email.
Okay, thank you. Yeah, we'll have to catch him on a next call or over email. I appreciate your input. Thank you. What fits in the definition of treated endocarditis? Is there a time frame? And there is a time frame.
I can take
So I
that one.
think the difficult part, oh, I'm sorry, who was speaking? I didn't mean to interrupt.
Well, go ahead, Chastity.
Oh,
Otherwise,
no,
I can
I
take
was
it.
going to say, in our definition of endocarditis, it essentially has to be active for us to use the preoperative factor of endocarditis. So we'll definitely have to look at treated endocarditis because it's essentially active to be per the Duke criteria of definition. We can include it as a diagnosis in the diagnosis list currently. And so we'll have to see if we're going to update that definition and how treated endocarditis, and it'll all be defined and explained in the training manual. But Melinda, do you have more to add with that?
Well, I mean, we have it clearly defined in our training manual. So, and I'm not sure if that's the intent. I'm assuming it is, since it's a purple field, that it's going to be
is,
the
yeah.
same as the
It's-
adult field.
Oh, I'm sorry. Yes, it's adult only. It's not.
No, it's not. It's for everybody. And we are
Oh.
going to collect it for everybody. If there's a history or if it's active, will be coded for everybody. So it's going to change a little bit in how
Oh,
it's
okay.
currently
Got
done in the congenital population. But here's the, and you can talk to this, Melinda, if you'd like.
Yeah, so endocarditis in the adult world is people from birth to time of surgery. Have you ever had endocarditis? So that's the time frame. And then if you've had endocarditis within that time frame, and then we break it down, we want to know, is it active? Are you actively getting the patients getting antibiotics or being actively treated for this endocarditis? Or is it treated endocarditis, meaning that it's been treated in the past? You're not currently on antibiotics. You're not currently receiving treatment for it. That's how it's broken down.
Yeah. Thank you. Next question for AFib or AFlutter under pre-op. Why ask if prior to OR? So should all pre-op factors? Yeah, you could take this one.
Okay, so in the adult population, we ask this one specific question. Of course, we ask If you go back to there, we ask, do you have AFib or do you have a flutter? And then we want to know if it's remote or recent. We have pretty clear definitions as to what remote is and what recent is. And then we break it down further. We want to know, is the patient actually entering the OR in AFib? And that would be, typically, we find that on the anesthesia record, the first rhythm that's documented. And if the patient is in AFib at the time of surgery, then we do not code AFib as a post-op complication. So that's why we ask that question.
That's right.
Otherwise, if the patient had AFib a week ago, they go into the surgery in sinus rhythm, post-op, they have AFib that's treated, then that is a complication because they did not enter the OR in AFib. So they had recurrent AFib post-op. So that's why we ask that specific question. It helps us to determine whether they had a recurrent AFib post-op as a complication.
Thank you, Melinda. This is helpful to go over the DCF. Do you know when the definitions themselves might be available for us to see? It would be helpful to start learning how all of these new fields will be defined. So we have the data specifications have the high-level definitions for these fields. And I think the intent is that we'll probably post them within the next month or so. The training manual is what should be used when coding these fields when you start actually abstracting. Anticipate, I think Melinda and Chastity will work on that and do our best to have it out by mid-June. Mid-June. It's a big undertaking. There's a lot of fields to work through, and working through any type of discrepancy between how the congenital group is collecting it versus how it's clarified in the adult training manual will need to be worked out between the surgeons. We've already done quite a bit of that work on the upgrade calls, but there's still some lingering questions that need to be addressed when they start that process. The only other recommendation I have, if you don't want to wait that long, is these fields here that are in green, or if you see them in orange, this short name. This is going to be the short name in the adult training manual. So you can find it. You can find it in the adult training manual just by searching on that short name. And this is currently the definition. It might change a definition intent clarification. It might change slightly, but for the most part, there shouldn't be too much of a change. But if you want to get started early, this is where you could look for these adult fields. Is there any way to calculate child PUE class if our MDs are not charting it? Melinda, would you like to take that one?
Well, in our training manual currently, and like I said, Carol said this could possibly change, but we do not allow the data managers to calculate it. It has to be documented by either a surgeon or physician, advanced practitioner, PA. Otherwise, we just code unknown if it's not documented by a provider.
Right. Thank you. And I didn't see Ruth's question, but it says, I think the top field need to be reworded and remove known or have the option to select no pre-op factors. So the reason why we had to add in these fields, pre-op factors known, yes or no, and we couldn't have an option of no known present, is because we this is a multi-select field, and you would have the option. It would allow you to have an option to code no and select multiple factors without having any checks in place. So this is the check to ensure that if you select no, then you don't code any. These will not open up further. If you code yes, then this field pre-op factor multi will open up with all of the choices available for the right population. And then Ruth says, if there are no pre-op factors present, we choose pre-op factors known. No, that's correct. So if there are no pre-op factors known, then you will code no. Okay. So I think we're probably pretty good to stop there. I think we got further than we expected today. which is good news. I'm going to update the slide deck to say that we got through the pre-op factors. And of course, we can always revisit these on the, the last webinar we hold for the upgrade will be just questions and answers. So we will be able to revisit those, revisit questions at that time. If you have, if as you're going through this, you have any updates or any questions you want to ask us, we can certainly do that then. Next question, I'm not sure about this one. Have there been any conversations about secondhand smoke exposure for PEDS patients? Anybody want to take that one?
I'm happy to weigh in on it. I don't believe that there were any conversations, or if there were, I wasn't present for them about picking up that they're smoking in the household. No, they're looking at patient smoking.
Yeah.
Or maternal smoking now in the pregnancy complication.
I have a question on that, Chastity. If there was secondhand smoke in the house, would they be able to code anything like an other option?
You can code anything you want in other, but there's no requirements to other. So it doesn't mean that I'm coding that in other.
Okay.
There's no comparative, data available, but yes, you yourself can code anything in other and free text that, as long as other is still available with free text. Yes.
Okay, very good. All right, well, I'll update the slides. The next call will be, we have our next webinar will be next Tuesday, and that is the monthly webinar for congenital. It will not be an upgrade webinar. That will be a monthly webinar, IQVIA updates and STS updates and education outside of the upgrade. That call is scheduled to take place on congenital go. It's scheduled to take place on February 15th at noon Central Time. The next upgrade webinar is February 22nd at noon Central Time, and Chastity, Leslie, Leanne, and Melinda will be leading that one. So they'll walk you through on the next couple sections and answer your questions. So the other question, we got one last question, and then we're gonna end the call. It says, my surgeons are interested in malnutrition as a pre-op factor. Just wondering if there were any discussions about that for this version upgrade. Chastity?
No, not that I'm aware again about malnutrition. I think sometimes it can be difficult to define, and failure to thrive is something we definitely see in all of our charts, and it's one of those things that we include as an other factor since we know it matters. But no, it is not going to be included in this upgrade at this time.
Okay. I guess we're going to end there. We're going to start the next upgrade webinar on February 22nd. We'll start at preoperative lab testing, and we'll probably get through preoperative lab testing and medications. And I guess that's it. So thank you so much, everybody. Thank you, Chastity and Melinda and Leslie and Janet. Thank you, Owen, for jumping on this side with us. I hope you all have a great day. Thanks, Leanne.
Thank you.
Carol, thank you.
Thank you. You did
I
awesome.
hope you all have a great day.
Great call. Good job, Carol.
Thanks. Bye. Bye, everybody.
Thank you.
Thank you, Owen. Bye.